and welcome to today's PHO Rounds presentation on respiratory season 2025-26. This is part one, surveillance and testing. My name is Dr. Julianne Coos, Deputy Chief of Microbiology and Laboratory Services, and I have the great pleasure of moderating today's session. Before we start today, let's take a moment for our land acknowledgement. Today, I'm speaking to you from Toronto. Toronto is situated on treaty land, and I acknowledge and respect the traditional and ancestral territories of First Nations, Inuit, and Métis peoples, whose land we are hosted on. I acknowledge that we are on lands of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, Haudenosaunee, and the Wendat, and I am thankful for the enduring hospitality of the peoples across Turtle Island that allow us to live and work today. I stand as an ally with all Indigenous people, past and present, in promoting the wise stewardship of the land, sky, and water of Ontario since time immemorial. I'd like to now introduce our speakers. It's my great pleasure to introduce my colleagues, Michael Whelan and Dr. Maan Hasso, as well as panelist Dr. Mary Choi for today's presentation. Michael Whelan is an epidemiologist lead in the Communicable Diseases Control portfolio at Public Health Ontario. His portfolio includes influenza and emerging respiratory viruses, tuberculosis, legionellosis, and invasive group-based streptococcal disease. Dr. Maan Hasso is a medical microbiologist at Public Health Ontario and is the lead for respiratory viral detection. He completed his medical degree as well as a master's degree in medical microbiology from Baghdad University in Iraq. And in 2020, he graduated from the medical microbiology residency and fellowship program at the University of Toronto and completed the certificate in medical microbiology from the Royal College of Physicians and Surgeons of Canada. And finally, Dr. Mary Choi is a senior medical consultant at the Office of the Chief Medical Officer of Health, Public Health. In her current role at the Ministry of Health, she provides public health advice and expertise to support the province's policy and program development initiatives aimed at advancing health equity and improving population health outcomes. I'm now going to pass this to Michael to get the presentation started.
Thank you very much, Julianne. So the learning objectives for today's rounds are that by the end of the session, participants will be able to summarize current epidemiological trends in influenza, COVID-19, and respiratory syncytial virus, or RSV, in Ontario, Canada, and internationally, to identify where to find Public Health Ontario resources on respiratory viruses in Ontario, and to describe the testing options available in Ontario for influenza, COVID-19, and RSV for the 2025-26 season. So we'll start by going over COVID-19 influenza RSV activity from the 2024-25 surveillance period for Ontario, then Canada, and then looking at international activity. We'll talk about some considerations for the 2025-26 surveillance period, provide some updates on Public Health Ontario surveillance products for 2025-26, and then go over COVID-19 and seasonal respiratory virus testing for the 2025-26 season. So starting with respiratory virus activity in Ontario for 2024-25, just a few things before we start looking at some of the graphs. Percent positivity from laboratory testing is the primary indicator of activity that we have in our Ontario respiratory virus tool. However, other indicators are available and we do monitor those, such as outbreaks in institutions and public hospitals, as well as cases, and those typically follow patterns that are similar to percent positivity. We also have severity indicators that we monitor, such as hospital bed census data and COVID-19 deaths. Those typically lag behind percent positivity. So in general, last season, so COVID-19 activity, it peaked between September to December. And that was similar. The peak in 2023-24 happened in the fall as well. And for flu, activity in 2024-25 was late and quite a lot larger than in the previous 2023-24 season. We saw higher percent positivity, more cases, higher hospital bed occupancy, and more outbreaks of influenza in the 24-25 season. For RSV, it peaked in December, which was similar to 2023-24 and also to pre-pandemic seasons. And a note that, the timing and size of the peaks tend to vary by age group, and we'll see some of that in the upcoming slides. So looking at COVID-19 activity in 2024-25, this graph shows in the orange bars the numbers of tests for SARS-CoV-2 on a weekly basis, and the black line shows the percentage of those tests that were positive. And so you can see there was an initial peak in late September of 2024 for percent positivity, and then a decline, but a secondary peak happened in December and early January. It's less visible in the percent positivity data, but much more apparent when you look at the case outbreak and hospital bed occupancy data. At that time, there was also a large increase in the number of tests being performed, and you can see that in the orange bars. So after a period of decline in COVID-19 activity and quite an extended period in the summer where we had low COVID-19 activity, but it was still there, we ended up having an increase starting at the end of July, and that increase continued into September and has continued up until this most recent week where there was a slight dip. But we'll have to see how that plays out over the coming weeks. And this particular graph does mask some differences that you can see by age group. And so the next graph I'll be showing is looking at percent positivity by age group over time. So the dark blue line is percent positivity in people 65 years of age and older, and the red line is for percent positivity in children under the age of 1. So percent positivity was highest in people 65 plus for most of the fall in 2024 before declining. And then more recently, over the course of sort of from May over the course of the summer, percent positivity has actually been highest in children under the age of 1 and started increasing in that age group before it started increasing in other age groups. And this is something that we hadn't really seen until this past summer. So now taking a look at influenza activity for 2024-25, the graph is the sort of same layout. Orange bars are the number of tests. The black line is the number of the percentage of those tests that were positive. You can see an increase that sort of started around mid-November and kept going up until almost a quarter of the tests were positive for influenza A. And the peak happened in February, which was quite late, later than you would normally see for influenza. The last season was H1N1 dominant season, so that marks 2 years in a row where H1N1 was the dominant circulating subtype, which is a little bit unusual. And in the graph, I didn't present influenza B activity. It was limited. And it occurred and peaked in the spring, as is sort of typical for flu B. Now, this particular graph does mask differences by age group again, and so when looking at influenza A percent positivity by age group, The sort of pink line is children ages 5 to 11, and the orangey line is children ages 1 to 4. And so you can see around mid-November, the increase occurring in those age groups first and fastest, and also to a higher percentage of tests that came back positive in those age groups. And the peak happened a little bit earlier in those age groups than it did in people 65 years of age and older, which is the dark blue line, and actually is the one that is the lowest on the graph in terms of percent positivity. So one of the things that we'll be keeping an eye on this year is, percent positivity in children, and seeing that as once it starts to go up, it's an indication you're probably going to start seeing increases in other age groups on a little bit of a lag. So moving on to look at RSV activity in 2024-25, the increase began in late September and then peaked in December before declining. And one of the things with this is that there's quite a difference in terms of the age groups. It's even more so than what we saw for flu. So on this slide, you can see percent positivity by age group. The red line is children under the age of 1. The orangey line is children 1 to 4 years of age. And so you can see the increase in RSV percent positivity started in those age groups well in advance of the other age groups. It peaked at much higher percentages of tests coming back positive, and peaked earlier than in adults. When you look at the hospital bed occupancy, the hospital bed occupancy was also highest in those two age groups for RSV, followed by adults 65 years of age and older. So how did Ontario compare to the rest of Canada? This graph looks at percent positivity for SARS-CoV-2, influenza, and RSV for Canada. And you can see that there was a SARS-CoV-2 peak sort of in late September nationally, followed by a peak in RSV in late December, and then a peak in influenza in mid-February. And that's very similar to what we saw in Ontario. And really what it comes down to at the end is that this sort of extended period of respiratory virus activity from September all the way until well into the spring, when the flu activity finally drops off enough. Nationally too, for influenza A, the dominant subtype was H1N1, so that's also the same as what we saw in Ontario. So now looking at international activity for 2024-25. So for some of the countries in the Southern Hemisphere, Australia, New Zealand, and South Africa, we looked at their reports, and the respiratory virus activity in 2025 for those three countries was fairly typical. COVID-19 for Australia, it peaked before flu and RSV, and they had fewer cases than in 2024. For New Zealand and South Africa, they had low COVID-19 activity. For flu, the timing of the peak in Australia was similar to 2024. They had an influenza A H1N1 dominant season. For New Zealand, they had influenza A H1N1 and influenza B co-circulating in sort of closer proportions to each other. And for South Africa, their flu season started earlier, but they had low activity throughout, and they actually had a H3N2 dominant season, so different from what was seen in Australia and New Zealand in terms of the dominant subtype. And for RSV, Australia had fewer cases than they did in 2024, and they had the highest case rates in 0 to 4-year-olds, which is similar to what we see here in Ontario. For New Zealand, they had a typical activity. It was a little bit later than prior years. And for South Africa, their activity peaked in April at a moderate level. So there's nothing that really stood out as particularly bad in terms of the seasons and for these three in those three countries. So for Northern Hemisphere countries, for COVID-19, looking at the United States, the European Union, and the United Kingdom, they all had the highest activity in fall of 2024. Um, and the activity in all three areas sort of increased over the summer of 2025. And when I was putting the slides together for the US, it looked like it was slowing. Now their graphs make it look much more clear that it's been declining. For the EU, it may have peaked. They've kind of leveled off a little bit at the end of August. And so for flu and RSV, the United States and the EU had similar timings of peaks to Ontario. So that was, to remind you, December-ish for RSV, February for flu. But in the United Kingdom, the peaks for both RSV and flu were earlier by a month or two compared to Ontario. So what might the 2025-26 season look like? So what are some of the things like that we could say might happen in this upcoming season? Well, it's a fairly safe bet. We're going to have circulation of SARS-CoV-2 leading to COVID-19 cases, influenza and RSV in the community. We expect that. Predicting when the peak in activity will occur is difficult. There have been some studies looking at modeling that people have tried predicting. Usually, once they get to 2 weeks, that they can't get much accuracy after that, and the accuracy already starts declining by the time they get to 2 weeks. But based on current and past trends, we're probably looking at a COVID peak sometime in the fall. There could be a second peak later. We'll see. Flu is probably going to peak in December or January, but anything more like specific than that at this point in time it can't is really difficult to do, and it would be quite rare if we had a H1N1 dominant season again, because that would be sort of 3 years of H1N1 dominance in a row, which would be I can't remember a three in a row in any time uh, recently. And then for RSV, it'll probably peak in December or January. It's kind of hard to say. Same idea. And while we do look at the activity in the Southern Hemisphere to see, what might be in store for Ontario, um, the Southern Hemisphere activity might not be a reliable predictor for Canadian activity. There was a study done by Public Health Agency of Canada that tried to take a look at that, and they found that it wasn't necessarily a reliable predictor for, like the Australian activity was not necessarily a reliable predictor for what might happen in Canada. So we'll see what happens. And so to that end, we put out a lot of different reports during the course of the year in order to keep track of what's going on with respiratory virus activity, as well as to make sure that people are also able to access that information. And so capacity building is going to be putting in some of the links where you can go on the PHO website to find different resources. So the first one there is just to our main respiratory diseases page. So when new reports come out, those will be featured there, and you can find reports there, as well as the link for the Ontario Respiratory Virus Tool. That tool is updated every Friday. And it has a lot of useful information in it on what's taking place for flu, COVID-19, and RSV in the province, as well as for some percent positivity information for other respiratory viruses that are included on the multiplex panel testing, and Maan will be talking about that test later. Other reports that we have that we produce are the Integrated Respiratory Virus Risk Indicators for Ontario report. We generally refer to that as our projections report. It provides short-term projections of respiratory activity, and so the next version of that is going to come out later this week. The latest one on the website was produced in March, so we have a pause over the summer for that, but we're starting that up again. There's the SARS-CoV-2 Genomic Surveillance in Ontario report. That gives you current and projected dominant SARS-CoV-2 variants information. That's being updated on a weekly basis at this point in time. And then we have an influenza genomic surveillance in Ontario report, gives information on circulating strains, vaccine match, antiviral resistance. And that comes out twice, one partway through the season and as an end of season report. And then we have an end of season report for respiratory virus, a respiratory syncytial virus genomic surveillance. And that gives you information on circulating lineages. So we do have a number of enhancements coming to PHO products in the fall. So actually coming out this Friday. So we have enhancements to the Ontario Respiratory Virus Tool. We're going to be adding an in-season interpretation text from October to March in the summary section. We're moving to using only the OLIS data for the testing and providing only the OLIS data for the testing section. That's available from 2020 onwards for all the respiratory viruses that are included in the tool. We are going to switch to using, for the 2025-26 season onwards, influenza counts that'll be derived from and calculated from the OLIS data in place of public health unit reported influenza case data. There's more details on that in our technical notes. We're going to be adding in recent COVID-19 influenza and RSV hospital admissions information in the outcomes section. And we've updated the public health units available for selection in the tool to reflect the mergers that took place at the start of 2025. We also are going to be releasing an updated technical notes document. It's a great resource to know more about how different data are being presented in the tool and to get some details about, when they were extracted, all of that kind of information. And so the resource link for that is available in the chat. And I would encourage people, if they have questions about what they're seeing in the tool, to check in the technical notes, because oftentimes that information is answered there. We also have updates coming to the Integrated Respiratory Virus Risk Indicators report. There's going to be an addition of a 65 plus age group. We'd received questions throughout the year last year about whether that could be done, so it's being added. Previously, for flu and RSV, the data were for the percent positivity projections that were in there were based off of Public Health Ontario lab data. That's been updated to use the OLIS data to give a more complete picture of the percent positivity information for the province. And there's going to be a number of updated graphs in the report, and the latest version of that should be coming out later this week. I'd encourage you to take a look at it. It's looking really good in my opinion. And we do value your feedback. If you have any feedback on any of our products, please send your comments into us at the communicable disease control at ohpp.ca email inbox, and we take those into consideration as we go through looking at what other updates and enhancements we'd be doing to their tool. And so with that, I'll turn it over to Maan to present on the respiratory virus testing for the upcoming season. Thank you.
Yeah, thanks, Mike. So this portion of the presentation will focus on testing offered at the PHO. Um, as we all are aware, respiratory virus testing will uh, facilitate timely detection of the virus, and this will support direct patient care, which will offer direct clinical intervention, the need of like an extra ancillary testing. The second portion is to focus on like informed public health response strategies for mainly for the management of like the public outbreaks. And the third component is to serve like the surveillance through looking at trends through over time, circulating viral strain and genomic characterization plus geographical distribution across different health units and regions. So at the PHO, we'll focus mainly in this presentation at molecular testing. So there are two panels that are offered for testing. The first panel is like offered, it's called the Fluvid, which offered identification of like the four major like respiratory virus targets, which is the SARS-CoV-2, influenza A and B, plus the RSV. And you can see through the graph, as Mike did mention in his surveillance portion of the presentation, that the three viruses, they peak at the fall and the winter, apart from the influenza B, which peaks late in the spring. The next panel is more an expanded panel, which is, we call it like the MRVP, or the multiplex respiratory virus PCR. And this will goes beyond the influenza and A and B and RSV. It will offer also subtyping for the seasonal strain, both the pandemic H1 and the H3. Beside that, it will offer other viral detections, including parainfluenza, adenovirus, rhinovirus, and seasonal human coronaviruses, plus the human metapneumovirus. Just to ensure that, make it clear to the audience that the seasonal human coronavirus is a distinct virus and it does not cross-react with the SARS-CoV-2. From last season, if we look at this graph, it will show like the main two targets with the higher positivity rate are still COVID and influenza, beside the enterorhinovirus. As we know, the enterorhinovirus can, because it covers two targets and it has like different peaks through the summer and the fall, because it covers like both the entero and the rhinoviruses. Now we'll focus on the eligibility criteria. At this season, there will be no changes in the eligibility criteria for SARS-CoV-2. The guidance will follow like the ministry guidance, which is the main focus is to test to treat. So it will be offered to people above the age of 65 years old, 18 years old, and older who are vulnerable for have like risk factors to have a severe illness, people who are immune compromised, residents and patients in certain high-risk settings, for example, congregate living settings or like hospitals, apart from like an outbreak investigation in the context of any suspected respiratory virus outbreak. For the other respiratory viruses, so this season there will be offering more Fluvid testing, and this will include like the listed criteria here, which will cover like the symptomatic residents and congregate living settings, which are not in an outbreak, symptomatic residents beyond the first four specimen, which will be eligible for the MRVP, which we will talk in a bit, symptomatic adults who are admitted in the hospitals, and also staff and healthcare workers in a congregate living setting that are part of an outbreak. For the MRVP, it will be focused mainly on outbreak investigations. So it will be offered to the first 4 specimens from any declared outbreak. For inpatients, it will focus mainly on ICU patients, immune-compromised patients, and children under the age of 18 years plus pregnant individuals. Those all need to be admitted to the hospitals and showing symptoms. So as we stated, it's respiratory virus testing is not offered for asymptomatic individuals. The current guidance for this seasons will ensure PHO will fulfill the standard of care for offering respiratory virus testing. We advise and recommend the use of general test requisition when requesting any respiratory virus, COVID and other viruses, and to include the mandatory informations, which will include the patient setting, the medical conditions, and if there is an outbreak, so please include the designated outbreak number. We are not using more investigational numbers, which used to be offered for SARS-CoV-2 during the early days of the pandemic. So request comes with investigational number will not be processed. I'll go in a bit for some scenarios to support how to fill these requisitions. And as I mentioned earlier, the choice between the fluid versus the multiplex will depend on patient setting and clinical information. For example, in this scenario, we asked to the submitters, the health units, long-term care facilities to fill all the highlighted areas within the general test requisition, including 2 patient identifiers, the patient settings, the specimen types, and if there are any clinical conditions and the symptoms. So for example, in this scenario, there is a 48 gentleman who presented with symptoms of fever, congestion, risk factors, COPD, chronic obstructive pulmonary diseases, and the patient is an inpatient in ward. So this will permit the testing to have a fluid option. If we go to the next one, this is slightly different. It's also an inpatient. However, the patient is immune compromised, which has a renal transplant patient. So this will put the patient into the criteria to have both the multiplex, which is the expanded panel, plus the SARS-CoV-2. And the third scenario here, where you have a pregnant lady admitted to the hospital for symptoms of congestion, headache, body aches, and this will suit the eligibility for also both the expanded panel, which is the MRPP plus the COVID test. As discussed in the purpose of testing, PHO supports outbreak investigations. And if you look at this graph, it will show description of the outbreak investigations that has been carried out for the last season. And you can see for SARS investigations, they were around 40% from the outbreak that's been tested at PHO. For the respiratory panels, you can see a single target of 46%, or you have at least 2 targets, which is sitting at 13.4%. And if you combine both the multiplex plus the COVID testing, you can see around 85% of the investigated outbreak, there was at least a single target that has been identified. So for the outbreak, as I highlighted earlier, for the first 4 individuals within an outbreak, they will be offered the SARS-CoV-2 plus the MRPP. The investigation number needs to be, the outbreak numbers needs to be highlighted within the test requisition. Beyond the first 4, the individuals, residents, symptomatic residents will be offered the fluid testing. For the rapid influenza testing, it will be offered only at sites where molecular testing is not offered, which I'll come into that in the coming slides. If there is any additional request, feel free to communicate with the PHO customer service. If you want to add like an additional test, we can discuss it case by case. For the specimen types, as we know that the nasopharyngeal swabs are like the most sensitive specimens for all respiratory viruses. If you go through the test information sheet, there are a list of the acceptable specimens that can be submitted for either COVID or other respiratory viruses. Ensure to check the expiry date of the collection kit, which is both the media and the swabs, because expired collection kits will be rejected for testing. Make sure to include like both patient identifiers onto the, and they are labeled into the collection kits. Testing will be offered in different PHO sites. This year, SARS-CoV-2 and Fluvid will be expanded to other sites, which includes Hamilton, Kingston, and Thunder Bay. However, the multiplex panel, the MRVP, is still going to be offered through London, Toronto Central, Ottawa, and Timmins. Testing is offered across the year in the multiplex panel for the Fluvid and the SARS-CoV-2 for the 3 additional sites. It will be offered during the season, which is October to the March, and this will be assessed according to the seasonal activity. For the rapid antigen influenza virus, it will be offered only in sites which does not offer the molecular testing, which are 4 sites, PHO sites, which are Peterborough, Orillia, Sault Ste. Marie, and Sudbury. Those individual that fits into the antigen testing, they should fall only during an outbreak investigation and during the influenza season only. For turnaround time, PHO will ensure offering the COVID and Fluvid testing. Results will be available within 48 hours since the recipient of the specimen at PHO. For the MRVP, because it's an expanded panel, it might take like up to 4 days. The turnaround time could be subjective to some geographical locations and according to the timing of receipt of the specimen at the lab. The rapid antigen testing is usually within 24 hours if molecular testing is not offered. As we know, there are other respiratory viruses that's been offered and PHO support testing those, and this will include avian influenza, any novel influenza, beside the subtyping for the seasonal strain, plus any antiviral resistance for influenza, and Middle East respiratory syndrome coronavirus, which is the MERS-CoV-2 plus the MERS-CoV plus the enterovirus D68. We recommend using also the general test requisition to order these assays. PHO will continue this season to support influenza surveillance, and this will follow the same path from previous seasons. We'll continue doing subtyping, support hospital who doesn't have like the ability to do subtyping with some selection criteria, which I'll come through for the next slide. PHO also participates in collaboration with NML for antigen characterization and vaccine match. So a portion of specimen of influenza positive will be sent to NML for sequencing and antigen characterization. Plus like the areas that Mike highlighted, which also will be offering the genomic reports for influenza, the monthly report for SARS-CoV-2, and the single report for RSV. Beside that, Ontario still participates within the SPSN network, which covers 4 jurisdictions across the country, and this will offer vaccine efficacy studies for COVID and influenza. For the subtyping, the same criteria like last year. So we ask hospital labs who does not offer subtyping ability for H3 and H1 detection. They can send it to PHO for subtyping. If there are any cases that are suspected with animal exposures, those also are requested to be sent to PHO for avian influenza and subtyping. A patient at ICU also we recommend to send those to PHO for full subtyping and any suspected antiviral resistance. These are the links to the different resources that can be useful to you. The last slide, I just would like to send an acknowledgement to all PHO colleagues participating and supporting this presentation, including communicable disease, the microbiology and laboratory service, incidence outbreak response, and laboratory surveillance and data management. Special thanks also to public health units, Ministry of Health, and Ontario Health. And thank you. And I will ask Julianne to take the lead in the Q&A.
Hi, thank you, Maan and Michael. That was a lot of information, very insightful. We're going to move to our Q&A segment to answer some questions. We have a lot of them already. And if you have a question still, just a reminder, just post your question in the Q&A pod. We will try to get to all of them. I don't know that we'll be able to because there are quite a lot of them today. Okay, so let's start with, let's start with something for Michael. There's questions about, so I think some of the graphs that you showed were pretty striking in terms of the percent positivity for the pediatric patients. There's questions surrounding whether or not, like what this looks like in terms of total test numbers. And, is the threshold for testing children maybe different than for testing adults? And what would some of these trends look like if we look at total tests as opposed to percent positivity, total percent or tests that are positive as opposed to percent positivity?
Yeah, it's a great question. There's definitely a lot more testing in people over the age of 65 years. And so if you look at the total numbers, their numbers are going to be quite a lot higher. And so that is something to consider is how many tests are getting performed. But it does mean that our overall percent positivity that we're looking at is very weighted by the 65 plus age group. And so looking at the percent positivities by the various age groups does give us some insight on what might be happening outside of that 65 plus, which is for our overall percent positivity, more driving that. Yeah.
Michael, and this next one might be, maybe this would be for Maan as well as you, Michael. Do you think, were there any changes in testing practices post-COVID that could be influencing our higher case counts that we're seeing?
Yeah, I think one of the things that we've sort of been staying away from is comparing directly to pre-pandemic case numbers or data, because the whole sort of paradigm of testing is different now. The numbers of tests being performed for influenza are quite a lot higher than they were pre-pandemic. So in this presentation, I just compared to last year. So they're a little bit more similar in terms of the number of tests that were being performed. And so we did end up with more cases in this past season than the one prior. But yeah, like when you look at sort of post when COVID-19 showed up and the amount of testing is like way different. There's a lot more testing currently being performed. So a lot more case finding than would have been happening previously.
That makes sense. And I guess along those lines in terms of testing, there was no mention in your presentation about any data on wastewater testing. Do we have any of that information still? Anybody, any of the panelists or presenters? This one's for any of you.
I can go first. I'm going to pass on a link over to the capacity building to put into the chat pod. And so the wastewater testing, once the provincial system was wound down, the wastewater testing that's taking place in Ontario is being done by the Public Health Agency of Canada. They do post their data on their website, which the link is now in the chat. However, they're testing in just 4 different areas of the province: Kingston, London, Peel Region, and Toronto. And that covers about 25% of the population, but you can't speak for the whole province based off of those data alone. And so with the amount of time, is just focus on things that we include in our tool. Yeah, I'll stop there and see if anyone else wants to add anything.
Okay, that's helpful. Thank you for that link. I'll give this one to Maan. So you presented a lot of information on the testing eligibility criteria. Could you maybe distill that a little bit, just as for everybody, in terms of what has changed this year relative to what's like this year versus last year?
Yeah, sure. Yeah, so there will be more like offer fluid, and the rationale behind that is fluid targets are the viruses that there are specific antivirals that can be used. The main change that we used to offer children in the ER settings with MRVP this season, it's going to be changed. We followed like the standard of care. We looked into the guidelines, jurisdictional surveys across all provincial labs, and all follow the new the criteria that we presented today. So it will be more of value to offer the full panel for like the to cover the vulnerable populations, including pregnant ladies, individuals, immune compromised individuals, hospitalized children. However, the rest, adults, will still be offered like the fluid, which can support like clinicians, the submitters with the targeted virus they can use for specific treatment or any infection control practices that differ, and for antimicrobial stewardship also. So these are the main changes. Like it's still fluid will be offered, but the MRVP will be a little bit focused on like vulnerable populations. And in the past, MRVP data used to be used for the surveillance, and currently, as Mike mentioned, the ORVT covers like included the OLS data, which covers across all the province, not only PHO testing. So it will offer a very good indication of the surveillance across the province.
And can you just remind us about the turnaround time for both of those tests and how they differ?
Yeah, so once the specimen logged and received in the lab for the fluid and the COVID, it will be within 48 hours, sometimes even like shorter. For the MRVP, it will be up to 4 hours because it's only like four testing sites will offer the MRVP at within PHO sites.
Okay, there's like a lot of questions here. I'm trying to, how about, here's an interesting one about the requisition. So you had recommended the general test requisition. So there's other people who have been using COVID-19 and respiratory virus test requisitions. What's going to happen if they don't use the requisition that you're recommending? As well as what would happen to samples that may not indicate clinical setting or clinical symptoms? What are we doing with those tests or the requests?
Yeah. So for test requisition, the COVID requisition is still will be available. Those specimens will not be canceled. However, we encourage to use the general test requisition because it has like more the options to highlight, for example, pregnancy, immune compromise, which the testing criteria will indicate like the eligibility for fluid versus the MRVP. And this is the reason we are asking submitters to encourage them to submit the general test requisition. For the other question, if like it's time consuming for front end processing at PHO to look into these requisitions and to if the information is not full and available. The specimens will be still available, retrieved within 1 week from like specimen submission. So if there are any information requested, please call the customer service if you receive any cancellation due to incomplete information. The specimen can be retrieved and can be tested if it will fall into the criteria of testing. So you don't need to do a recollection because we have the specimens until 7 days from like the recipient of the specimen.
Thanks, Maan. Mary, this one might be for you, but maybe you could take a stab at it. Are there any places in the community where there will be COVID or respiratory testing for outpatient and community members?
So I can address a part of this. So the provincial program offering the rapid antigen tests to specific healthcare provider settings is still available. So if some primary care providers and other select healthcare providers may still be eligible to request to receive these test kits for free to use for patients within their clinical settings. In addition, with the recent expanded scope of practice, some of the pharmacists in the communities may also be offering the rapid antigen tests as well as offering the antiviral treatment for COVID-19 should the test come back as positive.
Thank you. Let's see what else. So this is an interesting one about, will the PHUs have access to local influenza case data again? Michael, that might be a good one for you.
So I think the reports of flu cases are still going to go to the health units, so they'll have access from there. In terms of the cases that we're going to be deriving from the OLIS data that will be presented in the Ontario Respiratory Virus Tool, we are looking to make those available to public health units via a shared site. And there should be more coming on that in the coming week or so to health units. So we're hoping to make them available there for health units, yes.
Thank you. And Maan, I guess, there is concern about turnaround time. Sometimes it takes a long time for specimens to get to a testing lab. Is there any way for requesters to have an expedited testing or request urgent testing when there's a long-term care outbreak or another challenging situation?
Yeah, so there is a document within PHO which supports especially outbreak specimens. So there are guidelines how to label those specimens, how to ship them. It's available at the PHO website, how to handle like those specimens related to the outbreak, respiratory outbreaks. This was implemented since the COVID and it's still available. Although we haven't seen much of use of it, but it's a resource available for health units and long-term care facilities to use to expedite like those specimens to be shipped in an appropriate manner.
Julian, I'm happy to jump in here as well. So specifically for long-term care and retirement home settings, we do understand, I mean, our PHO lab colleagues do their absolute best to be able to get the turnaround time as short as possible, but sometimes there are going to be some delays associated with getting back the test results. So we are encouraging homes to consider using rapid antigen tests for purposes of outbreak management in consultation with their local public health units, as well as submitting those first 4 specimens associated with each new outbreak for MRVP testing, so that we can still maintain a pulse on what's happening in our community in terms of what is circulating for public health surveillance purposes. In the event that the 2 results come back differently, we do recommend that you go with a lab-based result. But we are trying to promote and encourage homes to use and access rapid antigen tests where they can, just because once you get that positive test result, you can access the antiviral treatment quickly based on that result alone. There was one other thing that I wanted to touch on, and it's escaped me. Oh, sorry. No, I do remember, I lied. And one of the other things that we used to see with the lab turnaround times is there often is a lot of delay just in terms of getting the supplies, getting the test kits, getting the courier to actually deliver it to your local lab site. So one of the things that that we are really actively trying to encourage all settings that are sending out their test kits for processing is, as part of their respiratory season outbreak preparedness overall, before you head into the season, you really have nailed down those courier and delivery processes and partners really just down a solid path, so that you're not running into any issues during the season itself.
Thank you so much. Lots of great information. Sorry if we did not get to your question today. I just want to thank our speakers, Michael, Whelan, Dr. Maan, Hasso, and thank you, Dr. Mary Choi, for your insight. I will also just give a little plug for part 2 of the series. Next week, October 9th, we have the webinar on the overview of seasonal respiratory virus immunizations. And you can all expect to receive a brief anonymous survey for today's session. Please try to complete this to allow us to continue improving our programming. And thank you very much for joining us, and have a wonderful day.